Right. I guess we can get started here. Um, Long looks like you're on. Thanks for joining. Get rolling with the first case here. Um, can you hear me?
Hey Damien, yeah, I'm here.
All right. So here we go. First case: 31-year-old female presents with intermittent headaches and retroorbital pain for past 6 months. Occasional nausea and vomiting. No real significant history, and she's neurologically intact. So what are the next steps? Say she presents to the ER.
Yeah, I'd probably ask about, any like symptoms that would be concerning for like any sort of hormonal issues, and also get, an MRI with and without.
Okay, good. Um, so we got a CT first. They came to the ER with headaches, got a CT scan, and then they call you because this is what the CT scan shows. What do you see here?
Yeah, it looks like hyperdense midline lesion. Hard to tell from the cut, but maybe originating from foramen or Monroe. There's a speckled area that could be concerning for calcification, and then there's also clear associated obstructive hydrocephalus.
Good, awesome. Yeah, that calcification is a important point to note there as well. So as you said, you have to get an MRI. Ignore that this is a post-op MRI. I didn't actually see a pre-op MRI in the system for whatever reason, but um, describe what you see here on the MRI.
Mm. Yeah, so on the left, axial T1 post contrast. On the right is a T2. Looks like maybe not discretely contrast enhancing, maybe heterogeneously enhancing mass. Um, Either looks like arising from the septum or the atrium of the right lateral ventricle. Looks T2 iso intense. I think differential here would be broad.
Mm-hmm.
I would consider since midline lesion, maybe originating from foramen or Monroe, I'd be concerned for, like a central neurocytoma. I would say maybe also less likely interventricular meningioma, given it's not avidly contrast enhancing. And then maybe third on my differential would also be something like an oligodendroglioma, given the intratumoral calcifications.
Okay, good. Yeah, that's pretty solid differential. I think you hit the highlights. Any additional intraventricular lesions, subependymoma, ependymoma, cord plexus papilloma, a bit less common, but still could be considered. Oligodendroglioma is an important one. We'll see why based on the pathology, but that's also kind of important, although again, less likely it's intraventricular. And then I included colloid cyst on here. Just obviously, this doesn't really look like a colloid cyst, but lesions that are sort of central young patients presenting with hydrocephalic symptoms is something you want to kind of keep an eye on, or kind of consider in your differential when you're looking at imaging, especially if there's not a clear, large lesion like in this case. So what do you want to do for the patient as far as treatment?
Um, so definitely think she needs tissue for pathology. She has associated obstructive hydrocephalus, so she needs that treated as well.
Mm-hmm.
Um, so I think I would, obviously if she's in the ER, admit her to neuro ICU, EBD watch, then, can maybe plan for I would say like maybe like a stereotactic biopsy and then shunt, and then final plan pending the pathology, I guess.
Mm-hmm. I mean, do you think you can get more of this lesion out, than just like a biopsy?
Yeah, I think it's primarily intraventricular, so I think you could maybe do you could try for a you know uh, maybe try for a aggressive resection. I think it's difficult. I think the main thing is like I wouldn't know exactly how aggressive to be with my resection if I didn't have I guess pathology. But you could do maybe like an interhemispheric or maybe like a endoscopic approach for this.
Yeah, you can also come, like right frontal, come, via like a Vicor or kind of through the ventricle
Yeah.
and get into the kind of bulk of the tumor and debulk as much as you can. Send frozen, obviously, intra-op, and that'll kind of give you at least a rough idea of what, how aggressive to be as far as your resection. But good. So that's what was done. Right frontal craniotomy, resection of the intraventricular lesion. As you mentioned, EVD was placed intraoperatively as well, and preparation for, or to treat the hydrocephalus, and the patient ultimately did not need a shunt, fortunately. So we'll go to the pathology now. What was found intraoperatively. Dr. Goltekin, here you go. I have your slides here.
Yeah, good morning. You hear me okay?
Yes.
Okay, great. So on low power hematoxin Wilson sections, we see a fairly cellular tumor with round nuclei, with fairly uniform round nuclei, and a delicate
I think we lost you, Dr. Goltekin.
Can you hear me okay?
Now we can.
Yeah, it suddenly went away. Anyhow, delicate blood vessel pattern, round nuclei, moderately cellular tumor. Next one. On higher power, you can see the same thing, except that the cytoplasmic clearing is obvious. So again, in a hemispheric or cortical location, this tumor would be good for an oligodendroglioma with delicate blood vessels, round uniform cells, and cytoplasmic clearing, so-called fried egg appearance. However, this is an intraventricular lesion. Next. So we know that in this location, there are other tumors that can mimic oligodendroglioma. Off the bat, I could say, clear cell meningioma, clear cell ependymoma, and this particular tumor are mimickers of oligodendroglioma. You can see here that there is some perivascular clearing also in around those delicate blood vessels. Next. And this picture shows you those little button-like formations are rosette formations. So it's a challenging case, especially if you don't know the location and if you don't have access to immunohistochemical staining. I still would have voted for the correct diagnosis here again, but it doesn't show super characteristic elements. It's a mimicker. Next. So GFAP is very characteristic. It's negative in most tumor cells. As you can see, the blue are the nuclei of the tumor cells. You can see scattered cells with astrocytic character in between the more uniform tumor cells here. So, it does stain some astrocytic cells, but most cells are negative with GFAP. This is an interesting pattern. Does not look, ependymoma doesn't stain like this. Oligodendroglioma doesn't stain like this. So right off the bat, the GFAP tells me that we may be dealing with something else. Next. So this is NeuN, a very robust neuronal marker of more mature neurons, actually. So as you can see, this is wall-to-wall positive and nuclear positive. So this does not happen in typical glial neoplasms. So this tells us that this is a neuronal neoplasm of at least intermediate differentiation. Next. This is TTF1. That's an odd stain for neuropath, but more and more we are seeing this in different entities in some cellular lesions like spindle cell oncocytoma of the cella, chordoid glioma of the third ventricle, and this one. Next. Synaptophysin also supports neuronal differentiation. Wall-to-wall positive synaptophysin is a cytoplasmic marker. Next. Neurofilament also stains, not as robust as synaptophysin and Nu-N, but does stain more cells than GFAP. So everything points out to a neuronal tumor. Next. The Ki67 is low. It's less than probably 6-7%. And we didn't see any mitosis. We didn't see any necrosis or vascular proliferation. Is this the last slide of the immunos?
I believe so, yeah.
Yeah. So taken together, we conclude that this is a central neurocytoma, which really morphologically mimics oligodendroglioma, but there is compelling evidence from immunohistochemical staining that this is a neuronal tumor and does not have any atypical features. Heavily calcified intraventricular location. So the diagnosis from the pathology part is central neurocytoma, WHO grade 2.
Great, thank you, Dr. Cook-Second.
Mm-hmm.
So as he mentioned, so central neurocytoma, which is a good job, Long. Top on your differential. So again, generally occurs in younger patients between 20 to 40 years of age, but it's very rare, less than 1% of all, just even intracranial tumors tend to present with symptoms of increased ICP over several months, and commonly, again, located within the lateral ventricles, as well as attached more centrally to the septum. Again, as you mentioned, Long, and then it's hyperdense on CT, can sometimes or often see punctate calcifications, approximately half of cases, but not necessarily avidly contrast enhancing, and it's T2 ISO 2 hyperintense. If it's very large, it can be cystic, which was a little bit seen here as well. And again, treatment surgical resection can be curative if it's completely removed, but sometimes that may be, sometimes that's not possible, depending on the size. And again, treatment of hydrocephalus, as was done in the case here as well with an EVD, is important as well to consider. And as Dr. Cook-Second mentioned, it's got the similar fried egg appearance, Chicken-Wire pathology to oligodendroglioma on pathology, these kind of clear cytoplasmic areas around the nuclei. So it's a good board's question. You know, they may show you this, but then you have to take into account either the location and or some of the other immunohistochemical staining or molecular pathology. So they lack the IDH mutant M1p19q co-deletion that's characteristic of oligo, and it's going to stain positive for neuronal markers such as synaptophysin, neuron-specific immunolase, and it'll be negative for GFAP. So important to keep in mind as you're doing your board studying. It's a pretty good question that they may ask to differentiate the two. All right, next case. Who's on here? Vaidya, are you on?
Yeah, I'm here.
All right. So next case here is a 68-year-old male, presents to the emergency room with 1 week of worsening headaches, 1 episode of emesis, and also some left-sided hearing loss. Family also notes he's been a little bit more sleepy than usual at home. Doesn't have any past medical history that's significant, and he's neurologically intact on exam. And when you're seeing him in the emergency room, he is awake and alert and interactive.
Okay. Next step, I would get a CT scan. If he's truly getting more, progressively more sleepy, I'd be a little bit concerned for hydrocephalus in terms of dispo. I don't think this guy may necessarily be safe for the floor. He may need to go to the ICU.
Excellent. Good. All right. So CT scan was done. What do you see in the left image?
Yeah, so it's a sagittal CT scan. Looks like he has this hyperdensity that's kind of looks like it's obstructing the
Recording in progress.
yeah. It's weird. There's this hyperdensity here that looks like it's obstructing the fourth ventricle.
Mm-hmm. And what do you think those white, like, do you think just these white things are the lesion, or is it, or what might these be? The extra hyperdense?
I mean, those doesn't necessarily look like blood, looks more like calcification to me.
Mm-hmm. Good. And then the image on the right, just showing the kind of lateral ventricles. They're slightly large, but not overtly hydrocephalic. So that's why I included that image there. As you mentioned, it sounds like he may have sort of a hydrocephalic picture, especially this fourth ventricular outflow obstruction. Put him in the ICU. Probably doesn't need DVD just yet if he's awake and alert, but low threshold if he starts declining. So then we get an MRI. Next step. Now describe what you see on the MRI.
Yeah, he zooming in a little bit. Yeah, he looks like he has this non-enhancing lesion right there in the fourth ventricle. There's a small amount of enhancement internally, but otherwise looks well circumscribed. Yeah.
Yeah, agree. So very subtle enhancement, kind of heterogeneous enhancement. And then how about here? What kind of sequence is this in this kind of bottom middle picture?
Yeah, you've got a T2 there.
And what are these kind of?
Oh, he's got flavoids in there.
spots?
So could be like a cavernoma or possibly an AVM, but it would be very unlikely.
Yeah, you would expect it doesn't quite cavernoma is kind of more on like that popcorn appearance. Less likely that's going to be kind of within the ventricle as well, but that will kind of come into play as we talk about what would be on your differential then.
Yeah, I mean, since it's in the ventricle, I suppose you could consider an ependymoma. It would be weird for it to have flavoids like that, though. Let's see. It doesn't really look like
ependymomas can be vascular, so ependymomas can have flavoids. They tend to be pretty vascular.
Gotcha. It doesn't really look like a cyst, or it would be odd to have a met in this location. Or I guess since it's in the ventricle, you could also consider like a choroid plexus papilloma.
Mm-hmm. Okay, good.
Subependymoma.
Yep, exactly. And then the fourth one that would be less common, more in children than adults, would be medulloblastoma in this region as well. So you hit the highlights. What do you want to do for this patient?
Well, I mean, if the main symptom he's having is the intermittent hydrocephalus, I think this isn't really amenable to like a resection. It might be a little too difficult to get a biopsy. So I would probably consider like an ETV to try to divert CSF in some way and prevent him from getting worsening hydro.
Mm-hmm. You don't think you could get to this lesion here?
I mean, I'm not sure if it's possible to biopsy or resect it. Then yeah, I would say that. But if you can't, I would say try to just treat the hydro.
Okay. Tyler, what is there a particular surgical approach for resecting these types of lesions?
Yeah, we go get to the bottom of the fourth ventricle. We usually go like it's, oh God, what's the name? It's not skin, but it's below the cerebellum. I know we go infracerebellum, right?
Yeah, no, it's not exactly what I'm going for.
The
So,
tonsils.
yeah, exactly.
Tonsillar.
There we go. Yeah, exactly. So that's what was done here. This is obviously not the same lesion, but a pretty nice picture I found online about the tenodeal tonsillar approach. So what are these here that are kind of being retracted away? This here, and then this at the bottom, as you mentioned. That's in the name of the approach.
Got it. Yeah, thank you, Damien. Sorry, I forgot the name there.
Sorry, what was it? They cut out.
Oh, I just said thank you. Sorry, I forgot the name there.
Okay, so these are the cerebellar tonsils that are opened out of the way. Same on this. This is sort of a, you know.
actually knows the patient that's today or
Oh, are you there?
not. Yeah, I'm here. Sorry, let me walk away for a second.
Okay, sorry. there's a
Go
lot
ahead.
of
No,
background
you're good.
noise.
Sorry. Yeah, go for it.
So these are cerebellar tonsils here. So you kind of split, go in between the tonsils. What is this vessel that's commonly encountered in this region here?
That's the something cerebellar vein, right?
Well, probably pica. It's hard to tell if it's really an artery or not.
Oh,
This pica, loop of pica tends to be in your view during this, and then this is the tumor. Looks like the ependymal intraoperatively, and this is the brain stem here. So this is sort of at the floor of the fourth ventricle. And when you worry about this region getting too deep into the
You'd be the brain stem. You're
exactly in the facial colliculi. Okay. All right, so that's what was done, suboccipital craniotomy, T-lobular approach instead of a transvermian approach. If you did a transvermian approach to kind of get through this, what finding is commonly seen? What clinical syndrome would be seen from a transvermian approach? That's decreased by doing a T-lobular tonsil approach.
Transvermin, you can get cerebellar mutism.
Yeah, good. Okay, excellent. All right, so that's what was done for this. Now we'll go to the pathology. Dr. Gold-Second.
What is this telovelo? Is that a name?
It's the telochoroidea is kind of split.
Oh, telovelar. I see. Okay.
Yeah, telovelar. Yeah.
Got it. Okay. Thank you.
Oh yeah, that's just a typo. I was going to put telovelar tonsillar.
All right, so let's see the pathology. So the pathology is interesting. On low power, on the upper right hand, you see the calcifications. In general, there are patchy cellular areas interspersed by really low cellular areas. There are some blood vessels, some maybe cystic spaces here and there. Next. So this part has this, what we would call like bunching up or nesting of tumor cells with a lot of background fibrillary matrix. This part of the tumor looks like a subependymoma. Okay, we don't have perivascular pseudorosettes. We do not have true ependymal rosettes. None of those. Just a vast glial background and nesting of, cells. Very typical of subependymoma. Next. So, but in contrast, there are these areas, which was a minority of foci, higher cellularity. In the center, you see that red blood vessel surrounded by a relatively nuclear-free zone in the lower center, in the middle. And do you see my arrow? No, probably not. Anyhow, perivascular pseudorosette in the lower center, that red blood cell. Yes, exactly. That's the blood vessel. There's a nuclear-free zone, and then there is a whole bunch of dancing nuclei forming a circle around. Yes. But that's a perivascular pseudorosette that does not happen in subependymoma. So this is the ependymal part. Next. Here you can see a rosette in better, I guess, higher power. Yes, and there's the nuclear-free zone right around the blood vessel where the, cells are sending their processes towards the blood vessel, forming the so-called pseudo-rosette, perivascular pseudo-rosette. There's another one yes, exactly, that one. That also has a perivascular nuclear-free zone surrounded by nuclear. You just have to use your imagination a little bit. So these are perivascular pseudorosettes, and you can look at the cells here. They have inconspicuous nucleoli. They are round and oval, don't have mitosis, no necrosis, no vascular proliferation. So the grade is low, but the twist is that there is again a mixed tumor. Next, please, ependymal and subependymal component. So the ependymal component has the typical dot-like or punctate EMA positivity, as you see here. Those brown dots are, yes, so-called the dot-like positivity, classic for ependymoma. Next, this was epithelial membrane antigen. This is glial tubulary acidic protein, where you can see the rosettes better, and notice that the ependymal tumor cells around the rosette, they don't stain too much. There is that blue zone. But the subependymal areas around, they do robustly stain with GFAP and the rosette stains. So that's typical for ependymoma. The perivascular pseudorosette stains with GFAP, but the parenchymal tumor cells, they don't really take up too much stain. Next. So this was I saw this in consultation from Dr. Laxon, and my opinion was that this was a mixed ependymoma, subependymoma with a minor ependymoma component in the tissue submitted to us. Therefore, when it's an ependymoma, it has to start with a grade 2. Subependymoma is a grade 1. A mixture would be graded as a grade 2. That's it.
All right. Thank you, Dr. Goldsekin. So as you mentioned, ependymoma was diagnosis in this case. Two groups, PFA, typically more in children, PFB, or more in adolescents and the adult population, is seen here. The PFA group tends to have a worse prognosis overall, as you'll come to find out on pediatric rotation. Presentation, as was in this case, is typically due to CSF obstruction. There can also be cerebellar signs such as ataxia that patients can present with over time as the tumor enlarges. PFA groups tend to arise from more the lateral recess of the fourth ventricle, and PFB are more typically midline, kind of extending from the floor of the fourth ventricle near the obex, again, as was seen in this case. And they kind of tend to be sort of like toothpaste-like lesions where they extend through the foramina, Bluchka, and Magendie as they enlarge. Again, heterogeneous appearance on imaging, often with calcifications or cystic components. Complete resection is the gold standard, but again, not always possible given its location and or the size, vessel involvement, et cetera, in that region. And unfortunately, though, adjuvant therapies are not particularly effective. And so that's why the prognosis isn't as good if you're not able to get all the tumor out. And again, the pathognomonic ependymal rosettes that are sometimes seen on pathology, they're sort of halo or spoke wheel arrangement of tumor cells surrounding this empty kind of central lumen. And the EMA is positive in the luminal surface. But more commonly, as Dr. Goldsekin was mentioning, are these perivascular pseudorosettes that are seen. And those are GFAP positive in the surrounding cytoplasm, as again, Dr. Goldsekin mentioned, but not necessarily in actual tumor cells themselves. All right. Third case, Ahmad, are you on? Ahmad, are you there?
Yeah, I'm here.
Okay, great. So third case here, 69-year-old male, past medical history of HIV, substance abuse, comes to the emergency room with, was brought to the emergency room with altered mental status. Here's his exam. So he's awake and alert only to name. He's aphasic and he's moving, anti-gravity, but he's not really following commands reliably given his altered picture.
Okay. We have CT.
Yep. So CT scan here. Describe what you see here in the start with the regular non-con CTs.
Yeah, I mean, it looks like he has a pretty, pretty extensive left hemorrhagic lesion of some sort on the CTs.
Hmm. And so what would be your initially, so you see this, what would be like your initial management for something like this? If you see this, acute hemorrhage, what would you want to tell the ER?
Yeah, I mean, I tell the ER to kind of get an A line in him, keep his blood pressure under 140. Would also load him with giving some Keppra. On his age, I'd probably give him about a gram Q12. So I would start those initial management, and then get vessel imaging as well, which it looks like he had on he may have on the right over there. But that would be
Sure.
my initial stuff.
Good. Yeah. So it looks at this point, based on the information we have, that it could be just sort of like a lobar hemorrhage, unknown source exactly. So get vessel imaging. What do you see here on the CTA? This is one sort of representative cut. I know it's not a ton of information, but anything that looks abnormal to you? It's a little subtle, but here there's a little tiny kind of like 2-3 millimeter like sort of IC terminus aneurysm. Do you think that's responsible for what we're seeing on the CT scan?
No, I mean, this looks a lot more like a lobar kind of hemorrhage. So I don't think this is like this is maybe a little bit less likely to be aneurysmal. I don't think it explains the CTA for me.
Good. So anything else you want to get? Any other imaging? Anything else you want to do to try and figure out what's going on?
Yeah, I'd want to get an MRI with or without contrast. For someone like him, I'd be concerned more about like either like if he has a history of like metastatic cancer, hemorrhagic nets, or even kind of like infectious causes. So.
Okay, good. So what get an MRI? What do you see here?
Yeah, he has a kind of heterologically enhanced and contrast enhancing lesion. There's I think there's a good amount of blood within the lesion. So it looks like some necrotic matter. Also, I'd be concerned about like maybe like a maybe either primary infectious CNS causes, so like like a hemorrhagic tumor, or something maybe infectious as well. So given this history and being study positive.
And where do you think it's arising from? Do you think it's interaxial? Do you think it's coming from the dura? What does it look like, kind of based on some of these slices here?
It does look interaxial, especially on the flare. You can kind of see where the lesion itself is, and then the surrounding like kind of like cystic, kind of necrotic areas as well, and like edema that goes kind of more intraparenchymal. So I think it's kind of coming from like it's involving the cortex for sure, and it's like an intraaxial.
Okay, good. Yeah, here it looks like it could maybe be kind of coming from the enhancement from the dura, but I agree it does. If you look kind of on more of the slice, it does look intraaxial. And then it looks too like it, could be pretty hypervascular. Again, I didn't include all the cuts, but there's quite a few sort of relatively large vessels running through here. So is there something else additional that you might want to consider before treating the patient? Another imaging study?
Yeah, like an angiogram.
Yeah, good. So again, this is sort of just what do you see? What phase? I guess the best question here is what phase of the angiogram is this, based on what your differential is in terms of what type of pathology, what type of lesion this might be? How can you kind of use it?
Late arterial.
And why do you say that, and then how does it relate to the pathology?
So you can kind of see that this is probably like a.
It's like what is like this here, and these here.
Yeah, I mean you can kind of see like superficial like draining veins. Up top on the right. You also kind of see. Yeah, it's like I would say like the late arterial, early venous. Because you see some venous filling. You just the late aspect of the arterial phase.
And so, what if you have late arterial, like venous, seeing veins filling in a late arterial phase? What kind of diagnosis would that support?
more like a fistula, like a like a really big fistula.
Well, it'd be the opposite. It's like an EVM or officially you would see early venous filling because it's direct
Oh, sorry, yeah.
connection between the two. But if it's a tumor, you would see that it takes some time to go through the capillary bed of the tumor and then wash out into the veins, but it's still earlier than you would typically see. So this is commonly seen in large tumor blush, very vascular tumors. You see late arterial phase venous filling. So that's sort of what we're showing here. So assuming now this is a tumor, what type of lesion, what do you think it could be versus, again, as you mentioned, could be also like infection, things like that, given his comorbidities. What's on your differential?
Hypervascular tumors, we could think, relatively malignant. So you can think like high-grade glioma, GBM, would be on my differential.
Okay. So a couple different options here. Again, solitary fibrous tumor, we're suspecting it's coming more from the dura. Same with meningioma. AVM, as we discussed, again, less likely based on the angio findings. Glioma, also, considered things like toxoplasmosis, given his, HIV history, opportunistic infections. And then even, as you mentioned initially, like a lobar hemorrhage could be something like amyloid angiopathies, elderly could have, encephalopathy. So pretty broad differential here. It could be a number of different things, but again, we're most likely suspecting it's going to be some sort of tumor. So a left parietal cranium is done for tumor resection. And then here is the pathology.
So low power shows a very cellular tumor, especially on the top half of the slide, with dilated big blood vessels, and at the bottom and to the right, you see these acellular areas, light pink acellular area, that represents necrosis. So half of this slide is necrotic, actually, almost, and the rest shows highly cellular malignant neoplasm. Next. You can see here on your right, relatively normal brain, and on your left, the tumor. So you can see the difference in cellularity. The center is just a hemorrhage. Next. So on high power, on the right side, there is blood vessel with vascular proliferation. On the left side, there are tumor cells that morphologically phenotypically look like astrocytes with a purpurary background, pink cytoplasm, and I put some arrows to indicate the mitotic figures. So there are two mitotic figures. So putting it all together, astrocytic neoplasm with vascular proliferation, necrosis, mitosis. This is a glioblastoma CNS WHO grade 4. And this one shows the palisading necrosis. Again, on the right side, there's a vast area of necrosis. On the left, there is some intensification of tumor cell density right around the necrotic area. Exactly. Okay. And GFAP is strongly positive in tumor cells where the blood vessel is negative, serving as an internal control. And that's a vascular proliferation area. Okay, next. IDH is wild type, so if IDH is mutant, then you don't call this glioblastoma, you call it grade 4 astrocytoma. But in this age group, how old was the patient?
68.
Yeah, so above 55, if the R132H exon 4 mutation is negative by immuno, that's sufficient to say that this patient's tumor doesn't have an IDH mutation. And that makes it a glioblastoma. Okay?
All right. Thank you, Dr. Gultekin. So as you mentioned, it's primary GBM, most common adult primary brain tumor, can be very heterogeneous appearing masses. typically centered within the white matter, regular peripheral enhancement, and the classic kind of hallmark is central necrosis that kind of separates it from the other lower grade gliomas, and can have a variable amount of surrounding vasogenic edema. So primary GBM is the IDH wild type, as in this case, which typically accounts for the majority of cases. Requires the following diagnostic criteria: so adult patient, diffuse astrocytic type tumor, IDH wild type, and then again necrosis or microvascular proliferation, TERT promoter mutation, EGFR, or the gene of chromosome 7, also chromosome 10 combination. So one of those criteria is also needed to make the diagnosis, as was the case here. And then secondary GBM are the IDH mutant ones that are transformations of lower grade astrocytomas into a higher grade lesion. Again, as Dr. Gultek had mentioned. So histologically, these pleomorphic astrocytes, they're marked atypia, numerous mitoses, as we saw in the previous slides, and necrosis and microvascular proliferation are, again, the hallmarks. So look for those kind of buzzwords on boards, questions as well if you ask a question about this. And the microvascular proliferation results in abundance of new vessels, poorly formed blood-brain barrier, which allows the leakage of contrast, and that's why you get that contrast enhancement. And then the differences, important to note, between multifocal and multicentric disease. So multifocal GBM are multiple areas of enhancement that are connected to each other by abnormal white matter signal, representing the microscopic spread of these tumor cells, versus multicentric disease, where there are multiple lesions throughout the brain, but there's no distinct white matter connection between the two areas of tumor. So they're separate centers of actual GBM tumors. And again, just to kind of review some of the basic treatment principles, Stupp protocol is resection of the lesion with then adjuvant temozolomide, 60 gray radiation, and 2 gray 30 fractions. And the RANO criteria was then developed, a couple other diagnostic criteria tools as well that have been used to assess the response to treatment in primary GBM and low-grade astrocytomas, which is based on the MRI and the patient's clinical features and kind of split into either complete or partial response, stable disease versus progression. And so the important points to note is a complete response is patients not on any steroids and are clinically stable or improved. And there's no evidence of enhancing lesions on the MRI, and stable to improved flare signal that's all sustained for 4 weeks. So that would be indicative of a complete response to the treatment, versus progression, where there's now new enhancement, 25% or more, despite patient steroids, patients doing worse. There's more increase in flare signal, or if there's any new lesions that are identified that weren't there on the initial imaging studies. Additional points, pseudoprogression, important to know, you'll probably get asked on this, and or radiation necrosis as far as boards questions, and understanding the difference between those. So pseudoprogressive increase in lesion size related to the treatment effects, typically within the first 3 to 6 months following treatment, but the patient is clinically stable. And so it's not an actual sign of tumor progression, even though it may look like that on imaging. Similarly, radiation necrosis can also demonstrate a mass lesion, kind of can look like there's new tumor growth, but the onset is more delayed, 9 months, anywhere from several years down the road. Patients can present with signs of radiation necrosis, and that's often with an actual neurologic deficit. And then that can be determined radiation necrosis versus actual tumor progression with an MR perfusion scan, which is something that, again, has commonly been asked on the boards. So important point to know. All right, last case here. Who we have on? Seth, are you available? If not, I guess let's come back to Tyler. I see you're on here still.
Yeah, I'm right there.
So it'll be a quicker one for the final one here. So 78-year-old female, she interestingly initially presented to an orthopedic surgeon with severe right knee pain, underwent a right knee replacement, uncomplicated, but overall postoperatively she continued to experience right knee pain, and then became more associated with right thigh and back pain, and ultimately developed recurrent UTIs and felt like she was having difficulty fully emptying her bladder. She's full strength, normal sensation, but kind of an antalgic gait, walks with a limp, more likely kind of due to her knee pain. So this patient presents to your clinic, say with nothing other than this story. What do you want to do?
But I guess I'd be concerned for nerve injury somehow during the knee replacement, but I'm not quite sure how that would affect like her bladder. I would expect the nerves to be higher up there. But I guess I get an MRI of the knee, but for any like nerve entrapment.
Mm-hmm.
Or
Where
maybe
else
of, like,
could her?
off of the pelvis,
Mm-hmm. And where else?
lumbosacral plexus?
Yeah, exactly. So you want like a lumbar MRI just to kind of
Okay,
see what's
lumbar,
going
okay,
on. Sounds
there
like
you
could
go,
be kind of radicular pain on the
Mhm.
right side, kind of thigh buttock pain.
Oh, I see. I did.
You know,
Okay,
could have
I got it.
you know
Okay.
some
Yeah.
caudal compression secondary to
Cool.
bladder difficulties.
Yeah.
So this is you get an MRI here. What sequence and what does it show?
There is P2 sagittal axial. What's that? 5, 4, 3, 2. L1, 2. Looks like there's extra. Actually, maybe it's intradural extramedullary lesion. At that level, is there a
Mhm.
contrast scan?
Yeah, good. So that's the next point here. So yeah, you can see intradural. Definitely, you can see kind of within the compartment here the nerve roots that are pushed ventrally. It's kind of I don't have like a perfect axial cut here, but it looks like it's below the conus as well, but sort of in that region here again at L12. So here's what the contrast imaging shows.
Okay, yeah, so it's contrast enhanced. Well, I guess unless I don't see a T1, but I'm gonna assume it's contrast enhanced.
This is the contrast scan. Yep. You can see the kidneys are lighting up here as well. So
Oh right, okay. Well, I mean like T1 without anyway. Yeah, okay. Sure, it's contrast enhancing.
So what would be on your differential for this contrast enhancing homogeneous lesion intradural?
Extramedullary, we're just concerned about meningioma or schwannoma first, and given its location, meningioma is more likely.
Okay. What other? There's two other types of lesions that could be in this region or kind of fit with the picture.
A
bit less common.
Like is neurofibroma? No.
Yep.
Oh,
that's
it
a
is?
possibility.
Okay.
Yep. So that's one of them. And then what other lesions that are commonly located in this specific area that we talk about?
Oh, like in the conus, you blank on the name. I'm not sure. I forget.
Second word is ependymoma. What's the first? What type of ependymoma?
What is it? I don't remember.
Okay, myxopapillary ependymoma.
Myxopapillary,
So that's another important one. Yeah, so that's another important one to consider for tumors in this location, kind of at the phylum to the conus. But again, as you mentioned, schwannoma, meningioma tend to be the more common ones. So don't forget about neurofibroma as well, and then myxopapillary specific to this location. So, going to resect it, L1-2 laminectomy, use intraoperative ultrasound. We've kind of covered, how to resect these spine lesions before. So we'll jump into the pathology here with Dr. Gutekin again. Dr. Gutekin, are you ready for the last one?
Can you hear me?
Yes, it's echoing a little.
Yeah. Is there echo?
It's a little better now.
Yeah, so I'm trying to fix it. Anyhow, there is a fairly cellular lesion, a lot of blood vessels. Yes, hyalinized blood vessels. Next. You can see here on the left, there is the loose areas, Anthony B. On the right, there is the Anthony A areas. Yes. And it's a spindle cell lesion. Next. Nice. And you can see the hyalinized blood vessels here. Thick hyalinized walls. Okay. Next. So here you see the spindle cell element. Elongated cells, no mitosis, no necrosis. Next. You can see a rare Verroque body. I put a square around it so that you guys can see the palisading of the nuclei and the central processes. So that's the Verroque body. So it's a schwannoma. There is hemosiderin in the center, those rusty brown areas. So there must have been some microbe bleeding in the past. That must be the last slide, right?
Yep.
Yeah. Thank you.
All right. So thank you, Dr. Goltekin. So, oh no. Okay. I don't think I'm echoing anymore. So thank you, Dr. Goltekin. So last one here is a schwannoma, most common nerve sheath tumor found in the spine. Typically, 95% of cases are sporadic and tend to be solitary, but as we know, often associated or can be associated with NF2. In patients without an NF2 mutation, but they have multiple schwannomas, it's termed schwannomatosis. Occasionally, we'll see patients like that as well that have multiple schwannomas throughout the spine. Typically, these lesions present with radicular pain and or numbness as they arise from the Schwann cells of the dorsal sensory rootlets. As was the case with this patient, had this kind of radicular type pain, typically solid, well-defined, rounded lesions, often associated with adjacent bony remodeling, you can see on CT. And when they're large, they may align themselves sort of along the long axis of the cord, growing precaudally in sort of a sausage-shaped mass. That can extend over several levels, or they may protrude out through the neural foramens, and it's termed more of a dumbbell-shaped mass. But typically in MRI, they often look very similar to neurofibromas. However, some things that may tip you towards a schwannoma is that they're associated with hemorrhage, as Dr. Goltekin just mentioned, intrinsic vascular changes, and often cystic formation and or fatty degeneration, which are all of those are typically not seen in neurofibromas. Again, gross total resection is curative, especially if it's sporadic. However, if they're NF2 related, there's a very high incidence of recurrence and or new lesions, and these patients need to be followed closely, and they rarely undergo malignant transformation. And then the picture on the right is just to sort of highlight again, I think I've showed this before in the past for neurofibroma, which would be group B, where they tend, or with a picture B, where they're sort of arising from the nerve itself and they're more intertwined with the nerve fibers. Whereas a schwannoma in the top picture is growing from the Schwann cell itself. And so while the nerves are sort of wrapped around it, it's not necessarily discretely directly from the actual nerve fascicles. So that's all we have today for you. I will turn it over to David. Thank you, everybody.
Thank you, Damien.
Thank you, Dr. Goltekin.
Good morning, everyone. So today's grand rounds, I just wanted to talk about severe traumatic brain injuries, go over a little bit of review on prior concepts around TBI care and the new considerations that came out after the most recent guidelines were published in 2016. So looking broadly at TBIs, there's a big consideration regarding the epidemiology of TBIs, looking into how frequently they occur and the overall cost of society that happens with them. There's an increasing body of research that looks at what the pathophysiology behind late TBI evolution is. So not just direct head trauma necessarily, but also related to the inflammatory cascade that accompanies a traumatic brain injury. I'm going over clinical considerations, updates, and management from the most recent set of guidelines, and then what the questions are moving forward in TBI research. So traumatic brain injury, as you all know, remains a leading cause of morbidity and mortality globally and within the United States. There's an approximate incidence of 27 million people who suffer a TBI on an annual basis around the world. Globally, falls are the leading cause of injury, followed by road and traffic accidents. And then when we look at a comparison based off the like socioeconomic diversity of nations and what the TBI index looks like, when you look at human development indices, which measures education rates, life expectancy, and per capita income, higher tier nations actually have older TBI populations, which would make sense given that the patients often tend to live longer. They'd probably suffer more falls as opposed to something more akin to like vehicular trauma or direct head trauma. Within the United States, the annual incidence rate is about 1 to 2 million per year, and that's less than the actual 2 to 3 million of people who come to the ER for TBI-like symptoms. In 2020 and 2021, there were approximately 214,000 TBI-related hospitalizations and then about 70,000 TBI-related deaths. That's the last year for which we have complete data from the CDC. 2023 and 2022 provisional data that came out recently shows that there's about 6,000 monthly deaths that happen related to a TBI, and a third of those patients tend to be over the age of 75. In terms of the other demographic factors, males are more likely to be suffering from a TBI, as well as 3 times more likely to die. And comorbidities include the polysubstance abuse, low socioeconomic status, and underlying psychiatric or cognitive disease that can contribute to one's TBI burden. Now, the more prevalent point, something I want to emphasize, was that there's a long-term disability prevalence with TBIs that oftentimes gets overlooked, which right now there's about 3 to 5 million people, so 1 to 2% of the US population that have disabilities related to TBIs. When we look at that financially, that actually ends up amounting to the fact that annually about $77 billion are spent on TBI care, 90% of which is during hospitalization, oftentimes for a severe TBI. The global annual burden ends up being about $400 billion. And when you look at CMS data, CMS actually, Medicare and Medicaid incur 3 times the cost of private insurance for the care of non-fatal TBIs. The cost presumably would be higher for fatal TBIs, though that data hasn't been fully analyzed yet. And for patients who do end up surviving a traumatic brain injury, the 2-year unemployment rate often is between 60 and 65%. So the overall social and financial cost of having a TBI is incurred not only by an individual patient or the family, but by society writ large. As I said, falls tend to be the more popular mechanism for a TBI to occur, but other things to consider are motor vehicle accidents, blunt force trauma, and with an increasing prevalence of firearms violence, that is now a major contributor to TBI, especially in pediatric populations. So when we want to study the overall impact of a TBI, large-scale data sets often remain limited. And the reason that happens is because oftentimes TBIs go undiagnosed. Either patients don't make it to the hospital in time, or they don't actively seek out medical care because the symptoms might be mild. Other times these data sets aren't comprehensive, so they'll exclude patients of the VA or active military members. In low and middle income nations, there's an absence of this database infrastructure that actually tabulates what TBI prevalence looks like, as well as the financial costs of having a TBI. So the areas where there's a higher prevalence of traumatic brain injury actually don't end up logging that data. And in a lot of cases, there's an absence of long-term follow-up in areas that don't have TBI clinics or TBI-related rehab programs that are affiliated with large rehabilitation hospitals. So we don't end up getting longitudinal data on what happens. And all this represents an opportunity for further research and asking how better we can understand the overall burden of traumatic brain injuries. But moving forward, if we look into the pathophysiology of what a TBI is, it's you know it when you see it. A traumatic brain injury is an alteration of brain function or pathology that happens because of an external force. Having a confound that's present, whether it's intoxication, sedation, that doesn't preclude the diagnosis, and the symptoms can be directly on arrival, they can be delayed, or they can be absent altogether. And there's usually 5 broadly categorized forces that contribute to a TBI. It's your head striking a dynamic object, a head striking a stationary object, acceleration, deceleration injuries, foreign penetrating bodies, and then ballistic forces, so things like explosions. And when we look at severe TBIs as a subset of this overall pathology, 56 to 60% of patients who present with a GCS of less than 8 also have additional systemic polytrauma. And 35% of those patients will need emergent neurosurgical intervention. Now, underlying this process are two distinct phases. There's an early phase that's the primary brain injury. That's where you've had direct injury to brain tissue, something like a contusion, an avulsed vessel, bone fragmentation, or diffuse axonal injury through a shearing force. But the secondary brain injury is something I wanted to cover today because that's the ensuing brain response to initial trauma. And it mimics a lot of other neuroinflammatory processes that are associated with neurological diseases that happen de novo. So 15% of patients who initially present with a benign presentation will rapidly decompensate. And that's part of this delayed phase response where you can get delayed onset hematomas, diffuse edema, hydrocephalus, seizures, metabolic derangements from neurophysiological alterations, thromboses, fistulae, meningitis, or even vasospasm, which ultimately argues for a continued role for observation and having interval surveillance imaging. So the mechanisms of a primary brain injury involve, like I said, direct insult to brain tissue. Their underlying process involves direct focal structural etiologies. So you get shearing injuries along white matter tracts, which can cause diffuse axonal injury. You get extraaxial vascular injuries, which can cause a variety of hematomas, parenchymal trauma, which can cause contusions, skull fractures, or even early cerebral edema. But there are molecular injury mechanisms that mediate a secondary brain injury response that happens diffusely. It may be initiated at the time of initial trauma, but this can extend to the days or weeks following a TBI. And there's multiple factors that can go into it. I'll review a few of these today. One is neuroinflammation, then there's protein aggregation that can happen, similar to a tauopathy. There's a mitochondrial, synaptic, and cytoskeletal damage, nerve degeneration or demyelination. Cell death can contribute to abnormal glutamate release, which can lead to excitotoxicity. You can have a metabolic crisis, and you can have intravascular coagulation that can contribute to local or regional ischemia as well. So this complex signaling pathway often can last for days to weeks, and one of the primary mediators for TBIs is actually the glial response. So astrocytes are often involved in aberrant neurogenesis and glial scarring, sometimes as a protective mechanism, but a lot of times that glial scarring can end up being a contributor to seizures and epileptiform activity. Additionally, astrocytes can end up releasing glutamate and having neuronal excitotoxicity that causes abnormal function in regions of the brain where there is focal TBI. And finally, deregulation of the astrocyte response can lead to the migration of aquaporin channels within astrocytes, as well as upregulation of TLR4 receptors that are related to neuroinflammation. And it can result in edema from blood-brain barrier breakdown. Similarly, microglia are involved in the inflammasome, and they end up going these phenotypic changes where they can go from neuroprotective to damaging, and they regulate the release of pro and anti-inflammatory signals through these phenotypic states. Ultimately, microglia, as we know, mediate the removal of cellular debris, but it's this deregulation of what phenotypic state they're in that contributes to the overall aberrant signaling that accompanies a TBI. And later on in this process, the innate immune system can get involved. So early research has shown that early pro-inflammatory signaling cascades develop within 3 days. Oftentimes, this involves pro-inflammatory cytokines such as interleukin-1b, which can peak between 6 hours and 1 day after initial head trauma, TNF-alpha, which can rise for the first 3 days, interleukin-6, as well as eicosanoids. The late anti-inflammatory response, and a lot of this immunoregulatory signaling can actually happen after 3 days, and this can involve things like IGF-1 and interleukin receptor 4A. So here, for example, is a demonstration of what the astrogliotic response is after a TBI. So you get an initial head trauma, you get astrocyte hypertrophy and proliferation, you get a glial scar, and GFAP expression increases. What this leads to is a variety of things. From increased calcium influx, you can actually get more glutamate release, which can contribute to excitotoxicity in neighboring neurons. You can get TLR4 receptor activation, which can lead to an increased release of cytokines. And you can get an increased amount of aquaporin receptor expression in other areas of the astrocyte, which can result in brain edema from blood-brain barrier permeability. And similarly, if you look at microglia, the microglial hypertrophy and proliferation after head trauma can result in shifts between their phenotypic states. So there's either an M1 state where they're pro-inflammatory, they're releasing cytokines that'll promote inflammation, or there's an M2 state where they're anti-inflammatory. And the timing of this response can ultimately impact how much of the inflammasome can be activated, as well as what proportion of inflammatory markers are active within regional brain tissue and result in some of these processes. So the cytokine cascade in the TBI begins within minutes. It's redundant and sometimes has counteracting effects. And one thing I want to focus on is TNF alpha and P53. So TNF alpha actually gets released immediately by glia neurons following a traumatic event and then subsides within 3 to 6 days. But the timing of this plays a crucial function. So early on, there's a neurotoxic function that TNF alpha plays, which can be a little bit paradoxical, but that pro-inflammatory response actually leads to further brain damage. So in rodent models, there's been an improved neurologic outcome that is associated with less blood-brain barrier breakdown, less edema, and less neuronal death when TNF alpha has been suppressed. And similarly, TBI cell lines often show that the expression of P53 and TNF alpha is actually upregulated relative to controlled cell lines, which is the immunofluorescence imaging on the top right. And in knockout studies, small interfering RNA mediated inhibition of TNF alpha has actually led to an improvement in cell viability in cell lines that mimic TBI. So in cells that undergo oxygen glucose deprivation and reoxygenation injury, similar to focal ischemia after a traumatic brain injury, those cell lines actually demonstrate greater viability at a delayed interval if you use small interfering RNAs to inhibit the expression of TNF alpha, similar to controlled cell lines. Later on, though, TNF alpha and P53 end up showing a neuroprotective function. So on the bottom, you see a couple of charts in a box plot regarding how rodent models who have TNF alpha and lymphotoxin A knockouts don't actually show a difference within 7 days for the severity of neurological injury. But after 7 days, the mortality is higher in TNF alpha knockout mice relative to wild type mice, suggesting that later on, TNF alpha may actually play a role in neuroprotective strategies within the brain, whereas early on, alongside P53, it may mediate apoptosis and cell death. Another factor to consider is interleukin-6. So unlike TNF alpha, interleukin-6 has been posited to play a role in inhibiting TNF alpha synthesis, inducing nerve growth factor release, and promoting neuronal differentiation, and counteracting some of that glutamate-mediated excitotoxicity that can happen after a TBI. So in rodent studies, again, absence of interleukin-6 has been associated with a delayed healing process. So these mice undergo aseptic cerebral injury where a cotton swab that's placed in liquid nitrogen is pressed against the skull as a mimic of direct head trauma. And in these knockout models where there is no interleukin-6, there's actually reduced tissue revascularization and cellular infiltration that happens, as well as increased necrosis, which is the chart on the top right. It's also associated with prolonged blood-brain barrier breakdown. And in mice that have transgenic expression of interleukin-6, even after TBI, there's actually greater cell proliferation with more healthy neurons that form anywhere from 4 to 14 days after head trauma compared to control mice that don't have transgenic overexpression, which is the H&E stain on the bottom right. So moving away from the cytokines and inflammatory markers, another consideration is the role of protein aggregation within brain injury. So tau protein is a microtubule-associated protein that provides cytoskeleton support and axonal transport in normal neurons. The hyperphosphorylation of tau protein triggers its release, and it leads to the formation of neurofibrillary tangles. This can be detected in CSF as early as 6 hours after a TBI. But what's been shown is that in TBIs, you get early tau formation oftentimes within 1 day. So in rodent models of TBI, on the ipsilateral side, they found that tau protein deposition has increased in ipsilateral cortical tissue, amygdala, and hippocampus, and oftentimes extending down to the brainstem. When you assess these models 1 week later, you actually start seeing that there's tau deposition that's in the contralateral hemisphere as well, that's not directly anatomically related to the site of trauma. It's modestly higher relative to control, but it argues for a role of this protein aggregation as playing a role in traumatic neurodegeneration. So broadly speaking, what's interesting is that this biomolecular profile that underlies the neuroinflammation of a TBI oftentimes has the same fundamental players that are involved in other CNS pathologies. So interleukin-6 and ICAM-1, which is an intercellular adhesion molecule that mediates the extravasation of leukocytes, has been pretty extensively implicated in aneurysmal subarachnoid hemorrhage and vasospasm as a mediator of the inflammatory response that accompanies vasospasm from blood breakdown products. Similarly, as you all know, tau protein aggregation leads to its own category of neurodegenerative diseases, including Alzheimer's and frontotemporal dementia, as well as now what we recognize as chronic traumatic encephalopathy. So there's an increasing focus that's come into play regarding identifying what are sustainable and accessible biomarkers for trauma and seeing if they can be incorporated into bedside and point of care testing to help triage TBI patients, as well as determine what overall prognosis looks like if we can get longitudinal data. So a few examples of these include S100B, GFAP, and interleukin-1B, and determining the big question within their study is whether or not the presence of these biomarkers in serum represents a process of neuronal injury that's actually severe, or is it just that there's blood-brain barrier breakdown? And looking into this is the focus of a lot of neuroinflammation research right now. The advancements in the last few years include that Abbott actually now has a point-of-care test for mild TBI evaluation called the Alinity-I, which is a serum assay for ubiquitin C and glial fibrillary acidic protein that's been available in Europe and in a lot of areas outside the United States since 2021. It's not FDA approved just yet, but it's something that's increasingly studied to determine whether or not patients who've had reported head trauma need to undergo CT scans or other imaging, or whether this point of care test can help determine the severity of a TBI. But moving away from the pathophysiology, we start talking about the clinical considerations. So one aspect that's has been overlooked over the last few decades has been how exactly do we communicate the severity of a TBI? So prior to the 1970s, an assortment of schematics existed for describing what a comatose patient was, but they were largely based off descriptions with no consistent or standardized metrics. There were anywhere from 3 to 17 steps, and there was very poor inter-rater reliability that characterized what was comatose because the language differed. Now, in 1969, Charles Fisher out of Harvard published a 56-page manuscript that basically summatively described the examination of the comatose patient and how to localize injury. And 5 years later, Sir Graham Teasdale and Dr. Brian Jennett out of Glasgow argued for a standardized approach looking at eye-opening verbal responses and motor responses to help standardize the communication of a comatose state across different providers with high inter-rater reliability, which ultimately came to be known as the Glasgow Coma Scale. But since the 1970s, there hasn't been any other scale that's been developed to better assess this. And progressively, there's been greater criticism of the use of a GCS score. First of all, it's an ordinal scale and it's non-parametric. So measurement on the GCS doesn't exactly represent a discrete quantity or it doesn't hold a value of its own. Similarly, it's non-linear. So a decrease of a GCS in one area doesn't necessarily equate to a decrease of GCS in another. As some of us have seen, it's very user dependent. So inconsistent exams, poor neurological assessments, or just not understanding how to do a GCS oftentimes lead to misreporting and can lead to delayed triaging of severe traumatic brain injuries. And in the setting of polytrauma and severe systemic diseases, oftentimes using the parameters of the GCS alone can be limited by confounds. Intubation also by default bottoms out the score for a third of the GCS score. And so looking at the breakdown of the component parts really matters. So even with a GCS of 11, there's a very stark difference between someone who's awake, following commands, and intubated versus someone who isn't. So out of the Mayo Clinic in 2005, they started to develop something called the FOUR score. It's called the Full Outline of Unresponsiveness score. And the limitation that it came with examining intubated patients and the lack of assessment for brainstem function in the GCS were key motivators behind this process. They found that in looking at the FORCE score, they looked at eye response, motor response, variability in the brainstem reflex, and the respiration patterns of the patient, even with being on a ventilator. And they found that they had a high inter-rater reliability within neurocritical care teams and MICU teams for looking at this score. And it was comparable to GCS. It allowed for further breakdown of GCS-3. So when you were able to incorporate the use of the brainstem assessment, you were actually able to have 4 additional scores underneath it that were able to be predictors of mortality compared to just saying that a patient had been GCS-3. And these were validated across multiple hospital contexts. However, since 2005, this hasn't actually gained any traction. So this remains an area where better communication regarding the examination of a comatose patient is something that still needs to be further validated or assessed, or provided with improvements in our understanding of the GCS score. Now, in 2016, the 4th edition of the TBI management guidelines came out. So the emphasis at the time was on evidence-based practices as a living guideline that was meant to be adapted. So they had said at the time that there wasn't going to be a 5th set, and they looked at the quality levels of evidence and had a much higher level of stringency related to evidence-based recommendations. Interestingly enough, there was only one evidence-based recommendation that actually counted as a level 1 high-quality evidence, which was that high-dose steroids were contraindicated in TBIs. But the remainder of their evidence-based recommendations were moderate to low, and the argument was at the time that there wasn't sufficient research going on into TBIs, especially with the use of randomized clinical trials, to look at whether or not certain interventions were actually effective or not. Since that time, though, there's been a growing number of active RCTs and an increased emphasis on data management that's modified practice. So I just want to go over a couple of the trials that came out since those guidelines came out, and go over the review. So the first recommendation from 2016 was that bifrontal decompression wasn't recommended to improve outcomes, because at 6 months post-injury, those patients didn't necessarily have a big outcomes difference, even though patients who underwent a bifrontal decompression had reduced ICP. This came because of the DECRA study, which was published in the New England Journal in 2011. And the fundamental question of the study was, does decompressive craniectomy in patients with refractory raised ICP improve their overall outcome? Over an 8-year window, they looked at about 155 patients who had severe TBIs, all adults, and they looked at whether the ICP had been elevated for 15 minutes or more in a 1-hour period, despite all prevalent first-line therapies being used. And if had been the case, the treatment arm underwent bifrontotemporal decompression. And they looked at 6-month extended Glasgow Outcomes Scale scores. And the results were that they found, as you would predict, that in the craniectomy group, there was a lowering of the mean ICP relative to patients who underwent just medical management. The craniectomy patients had a shorter length of stay and a shorter mechanical ventilation period, which wasn't significant, but it was a data trend. And at 6 months, the craniectomy group actually had a worse functional outcome and more unfavorable outcomes than medical management. So when you look at the extended Glasgow outcome scale, the lower 4 scores, meaning severe disability, a vegetative state, or death, had a higher prevalence for patients who actually ended up undergoing surgery than patients who didn't. But despite that, the recommendation was that for early ICP interventions, bifrontotemporal decompression could reduce ICP, but not cause an improvement in outcome long term. This, however, was published prior to the results of the RESCUE ICP trial. So the RESCUE ICP trial came out in 2016 in the New England Journal after the guidelines had been published, and the whole goal was to assess the effectiveness of craniectomy as a last-tier intervention for ICP, as opposed to an early first-tier intervention. So this study looked at about 400 patients over a 10-year period and looked at ICP elevations above 25 for anywhere between 1 to 12 hours, despite maximized tiered ICP treatment. And patients underwent either unilateral or bilateral decompression procedures at the discretion of the treating surgeon versus a control group that underwent medical management. And At 6 months, which was the initial study, decompression actually resulted in lower mortality. It was almost half. However, it was associated with poorer functional outcomes at that time. So similarly, there was an increased rate of vegetative state or severe disability, including dependence on others for care or lack of independence when patients were outside the home. But when we look at the Rescue ICP's secondary analysis, which was published more recently, this was a planned 24-month analysis of patient outcomes, and it showed that patients who actually underwent decompressive craniectomies still had lower mortality. They had higher rates of vegetative states and severe or moderate disability, but what they saw was that at a 24-month analysis, there was a significant difference in the patients who underwent craniectomy. Specifically, those patients who were actually able to demonstrate a greater rate of functional improvement in a 2-year window relative to patients who underwent medical management. And the argument is whether or not this was something that was not necessarily related to the decompression alone, but whether this was an effect related to undergoing a cranioplasty and treatment of any type of sunken flap syndrome pathologies. So this remains to be seen on whether or not the difference in net improvement is something that's reproducible for patients at even further intervals, so 5 years, 10 years down the line. But what this led to a stronger argument that at the late stages of elevated ICP in patients who are good medical candidates, surgical decompression can be useful in reducing mortality. The other big update that came to the Brain Trauma Foundation guidelines was cerebral monitoring. So with the advent of brain tissue oxygenation technologies, they transitioned away from necessarily using just jugular bulb monitoring and argued in favor of using oxygen monitoring as an adjunct to guiding treatment for TBIs. So what is jugular bulb monitoring? It utilizes measurement of the oxygen saturation of the jugular bulb as an indirect measurement of brain tissue oxygen consumption. The basics by how this works is that a fiber optic catheter is installed in the jugular bulb and allows measurement of oxygen saturation based off the light absorption profile of the blood. And it allows you to track the difference between arterial oxygen saturation that can be obtained from something like an ABG and the oxygen content of jugular venous blood to assess the metabolic rates of brain tissue. The big disadvantage, though, is that it captures whole brain tissue oxygenation as a proxy measurement through venous outflow. It doesn't necessarily capture focal ischemia or changes that are related to TBIs in only certain regions of the brain. The other part of it is this is an indwelling catheter that sits in the vessel. It can thrombose off. It could require revision. So this is something that has slowly been phased out and replaced now with partial brain tissue oxygen, partial pressure monitoring. So this is a newer technology that now known as the Lycox in our case, that helps enable direct monitoring of brain tissue. It's a microelectrode catheter that allows regional monitoring of brain tissue pH, temperature, and oxygenation for a more specific assessment of cerebral metabolism. So the Lycox, which is made by Integra, it's one of the catheters, not the only one, is an oxygen sensing electrode that actually tracks the changes in voltage between a reference and a measuring electrode as a function of molecular oxygen reduction across about a 7 by 15 square millimeter area of brain tissue. It's as oxygen diffuses across a semi-permeable membrane within the actual monitor itself, that oxygen gets reduced and a current is generated that a measuring electrode picks up. The average normal value is usually anywhere between 16 and 30 with a median of about 20 to 23. And it can be placed in through a triple lumen catheter alongside an ICP monitor as well. So the big argument for why this needs to be used came from a study in 2017 called Boost 2, which was a phase 2 randomized prospective clinical trial, which had about 120 patients who had both monitors placed, so an ICP monitor as well as a partial brain tissue oxygenation monitor placed. And they were either GCS of less than 8 or greater than 8 with a decline requiring invasive monitoring. And they were monitored for either 48 hours or up to 5 days if there was no improvement in the exam. And they underwent tiered management of either their ICP or both. The primary outcome was a 6-month outcome scale score on whether or not their functional status changed. And as one would expect, patients who actually had O2 monitoring tiered management spent less time with tissue hypoxia compared to patients who had just ICP management alone. The this trial was actually stopped early because the patients who underwent partial oxygenation monitoring trended towards having lower mortality and better functional outcomes compared to patients who just had ICP management alone. Analysis of the National Trauma Data Bank in the United States out of Syracuse in 2021 actually found that PbO2 monitoring had significantly lower mortality at 4 years down the line, with no difference in unfavorable discharge or length of stay relative to patients who underwent ICP management alone. So this led to an increased argument for utilizing PbTO2 monitoring, and it led to now a phase 3 trial. But before the phase 3 trial, before I talk about that, this issue of brain tissue oxygen monitoring led to an updated guideline from the Seattle Trauma Consortium, which is called the CIBIC guideline, which now creates an algorithm for gauging between ICP issues and brain oxygenation issues. And based off what quadrant patients fall into, there can be tiered management for optimizing both sets of parameters as a way of reducing overall mortality. So right now, Boost 3 is a clinical trial that's going on that's looking at the long-term outcomes for brain tissue oxygenation monitoring. And patients are being randomized again to either ICP monitoring alone or to brain tissue oxygenation monitoring. The monitors are removed by day 5, and they're looking at patients 180 days after injury, and similarly looking at whether or not patients need interventions for ICPs or for PbTO2. But what they're doing differently in this phase 3 trial at a broader scale is they have a sliding outcome where they're looking at the impact score, which is a score for gauging the severity of mortality, or predictive score for mortality in TBI. And they're using that as a way to gauge whether or not the outcome scale is going to be favorable or not favorable. The goal of this study is basically to standardize whether or not the use of brain tissue oxygen monitoring should become standard of care, because at this stage, it currently isn't widely adopted, though it increasingly is. So moving forward, where does this land us? Well, TBIs, especially in their most severe forms, represent a complex cascade of different mechanical forces that, when combined with a neuroinflammatory response, lead to a week to month-long period of traumatic brain injury that far exceeds just the initial traumatic insult. They have a significant social, financial, and emotional burden, but the molecular underpinnings of secondary TBIs represent targets that we can use to stratify the severity of injury, as well as find potential treatment areas for their long-term sequelae. Grading systems right now are pretty much fixed. It's exclusively just the GCS, even with its flaws. But looking into whether or not there's better ways to grade patients who are comatose or present to the trauma bay with other comorbidities would help triage and stratify the risk profile of TBI patients. And TBI guidelines themselves are an evolving process. So they were last updated 7 years ago. There's new information that's coming out every day, including for late stage interventions and bedside monitoring technologies for guiding care. And these interventions are fundamentally important because they're shown to actually reduce mortality. So ultimately, the long-term data doesn't exist just yet for these new monitoring technologies, but the implications on how they'll be used, as well as their applications in resource-deficient settings that may not necessarily be able to afford or have the critical care infrastructure, the neurosurgical infrastructure to do bedside monitoring. It raises a fundamental question on how we can extend this sort of higher level care to areas that don't have the resources to support it. So these are the broad questions in TBI now, and it's something that requires further research. But it's all I've got. So thank you, Dad.
Very nice talk, David. Yeah, great job.
I thought that was an excellent presentation. This is Dalton Dietrich. We've been working on the pathophysiology and treatment of TBI since the early 80s, where I worked with Don Becker and and John Pavlishak on trying to translate work from the clinic to the ICU. And you know, some of the things that we have been interested for many years has to do with the importance of temperature and looking at flow metabolism coupling and things like that. Where is the targeted temperature management area in terms of routine ICP management for severe TBI right now? David, do you have any?
Yeah, so based on the 2016 guidelines, actually early hypothermia wasn't recommended. There's a paucity of data in terms of larger scale outcomes for whether or not targeted temperature management can be used. It is used as a late stage intervention for refractory ICP issues. And brain temperature monitoring isn't something that's been regularly studied. I know there's some early literature that's coming out in favor of looking at it similar to brain tissue oxygenation, but it's not something that's been reliably evaluated for long-term outcomes.
I'm just wondering that, you know, in measurements of cerebral temperature in many stroke and TBI patients, it goes above normal. And I'm just wondering if people are still trying to maintain normal thermia. I'm not saying so much about hypothermic, but normal thermia to, you know, maybe not aggravate flow metabolism uncoupling and some of the other ionic issues that are occurring. That yes, but I know the hypothermia work hasn't panned out in large multi-center trials for various reasons. Maybe it doesn't work, or patient heterogeneity, or strategies for cooling patients. Those are all things we talk about. But I'm just wondering, in the ICU, is there a temperature, for example, that a patient has, core temperature, I guess, because you're not measuring cerebral temperature, that you would induce some type of targeted temperature management protocol if it gets too high? I guess that's my question.
Hi, Dr. Dietrich, Joe Gracioli. So yes, typically we struggle to have a pretty strict control with a good normal temperature, and some catheters can measure the core temperature as you're mentioning, and we really strive not to have hyperthermia or so, because it's detrimental given the increasing the metabolism. But as David mentioned, typically we use mild hypothermia around 35 Celsius as tier 2 in the CBIC protocol. So we do use the cooling blankets. Some centers use esophageal catheters to keep the patients normothermic and for mild hypothermia down the road.
Very good. Thank you very much. I also just say to this group, because it's a group interested in traumatic brain injury, we're just publishing a new paper. As you know, my project over the last several years has been obviously looking at human Schwann cells in peripheral nerve regeneration as well as spinal cord injury with Dr. Levy and colleagues. And we've just discovered that we can isolate the exosomes or extracellular vesicles from these human Schwann cells. And if you infuse those systemically, and it's now 2 models of one severe TBI and one more moderate TBI, we see that we get a reduction in overall contusion volume. We get a reduction in indicators of inflammation. Again, post-traumatic inflammation is extremely important as a target for therapeutic interventions. And it appears that animals are doing a little bit better. So basically, hopefully in the next several months, we will have the data all published, and we will be talking with our neurosurgical colleagues to see if we would like to continue to move this to both traumatic brain injury and spinal cord injury. The cargo of the human Schwann cell exosomes is very rich, a long list of proteins, lipids, and microRNAs that target some of the downstream signaling cascades in our that we think are important in secondary injury mechanisms in these acute injuries. So anyway, I'll keep you guys updated on this as we move forward, and hopefully in the near future we'll have a new cell-based therapy that doesn't involve transplantation of cells, but actually infusing the exosomes of cells. So thank you for the talk. It was very interesting.
Thank you very much, Dr. Dietrich, to let us know. You can count with our support. And also, I'd like to mention that regarding a non-inflammatory pathway, that alongside Dr. Libo's lab, we're making progress. It's in the context of this R01 we have from NIH. The DCRIN, which is an agonist for the NMDA receptors that experimentally was blocked, showing better outcomes in animal data. And we did the translation to the human tissue that we're sampling. It's present and it's also increasing in more severe TBIs and will be a future target for medical intervention trying to improve the delayed injury in TBI.
Outstanding. Thank you.
Dr. Dietrich, how is it infused, the exosomes? Is it intravenous, intraventricular?
In the
What's
animal
the-
studies, we're doing it in the jugular vein right now to maximize effect. And it looks like they're accumulating in parts of the brain, also the lungs, obviously, and other organ systems, which is interesting to think about because as we look at traumatic brain injury and stroke and spinal cord injury, it's really a whole body wellness issue that we're talking about. We focus on the major organ that's injured, and that's important. Everybody agrees with that. But in terms of what, for example, traumatic brain injury does to lung function and we've done now heart function, and now we're doing the gut function in terms of permeability changes and things like that. We may need something like, I was just saying, therapeutic hypothermia, or maybe a more systemic approach to targeting the multiple consequences of a severe a brain injury due to trauma or cerebral ischemia. So anyway, it's a new way. A lot of great research is coming out now, and again, being in a department of neurological surgery, it's really great that we can talk to clinicians that are seeing these patients every day and try to change medicine. So we'll keep in contact with you guys, and thanks for everything you do.
Absolutely. It looks very exciting. I'll be very glad to participate.
I guess that's all then. Have a great day, everyone. Take care.